Welcome back. Today we'll be discussing about some of the questions from CMS forms. We'll see the first question. He's talking about a 64-year-old right-handed man. Over the past 3 weeks, this 64-year-old right-handed man has had 5 episodes of blindness in the left eye lasting 12 to 20 minutes. His history is otherwise non-contributory. Which of the following is the most appropriate next step in the diagnosis? When I read the question, I could understand that this patient who has got 5 episodes of blindness in the same eye points me to a diagnosis of amaurosis fugax. Whenever I say amaurosis fugax, I will have to remember that amaurosis fugax is nothing but TIA of the eye or TIA of the retina. Whenever there is amaurosis fugax, it is an indication that the patient might be developing or might be having a impending stroke because of the involvement of the carotid artery. This is what you'll have to remember. So here comes the answer. Which of the following is the most appropriate next step in the diagnosis? Ophthalmological evaluation. Yes, I can do an ophthalmological evaluation in cases where I have got a sudden onset painless loss of vision, usually suggesting out towards central retinal vein occlusion or branched retinal vein occlusion or an arterial occlusion or vitreous hemorrhage is one thing I would like to think of whenever there is an ophthalmological evaluation. But this patient has got 5 episodes of blindness, which points that there is a recurrent episodes that are happening. Next, he is talking about 24-hour ambulatory EEG monitoring. This is usually done whenever the patient has got atrial fibrillation or any other cardiac abnormality. So this is not the option. Carotid duplex scan, yes, this would be my first choice because this is a case where the patient has got amaurosis fugax, and this patient amaurosis fugax can be a diagnosis for the underlying stroke. So I will select the option of carotid duplex scan. Next, we talk about CT scan of the head and MRI brain. CT scan of the head and MRI of the brain is usually done if the patient has got an underlying infarct or if you think that this patient has got a stroke. But this patient who has got 5 episodes of blindness in the left eye, each lasting 12 to 20 minutes, indicates that there is transient vision loss, indicating that this patient has developed amaurosis fugax. This amaurosis fugax, whenever we talk about amaurosis fugax, I want you to remember the causes of amaurosis fugax. It can possibly be because of the carotid artery embolization. Whenever there is emboli from the carotid artery, this can possibly be going to the retinal arteries or retinal vessels. That can be the cause of amaurosis fugax. Another most important cause for amaurosis fugax or a differential diagnosis for amaurosis fugax is possibly a temporal arteritis that could possibly be causing. But when the patient is talking, when the examiner is talking about temporal arteritis, you will have to remember that temporal arteritis usually presents with the jaw claudication or patient presenting with headache with the labs showing raised ESR. Obviously, for temporal arteritis, it is the biopsy that is the investigation of choice, and high dose steroids needs to be started in order to prevent the blindness. All right. Next, we talk about another question. Same for the MRI of the brain as well. If there is an impending stroke or if there is a infarct or a stroke, you'll have to remember that. All right. Next, we talk about another question. He's talking about a 77-year-old man who is brought to the emergency department because of a 2-day history of headache, confusion and blurring of vision. Remember the tempo of the disease, it is 2 days. He has not had any recent trauma to the head or eyes. He has chronic hypertension, type 2 diabetes mellitus, irritable bowel syndrome and bilateral hearing loss. Current medications are hydrochlorothiazide, glipizide, amlodipine, losartan and chlordiazepoxide. On arrival, he is holding his head in his hand. He is oriented to name and place but not to date of birth, month, year or the current president. His temperature is 37, pulse is 64, respirations are 12, blood pressure is 230 by 130, visual acuity is 20 by 30 in both eyes, visual fields are full. Fundoscopic examination shows blurred optic disc margins with several slit-like hemorrhage in both fundi. A CT scan of the head shows hypoattenuated areas in both occipital lobe and an old lacunar infarct in the basal ganglia and thalami. Which of the following is the most appropriate initial pharmacotherapy the examiner is worried about? He's talking about a 77-year-old guy who is presenting with headache, confusion and blurring of vision with a raised blood pressure of 230 by 130. What do you think of? This patient has basically got a hypertensive episode. If the patient has got an end organ damage, it is basically hypertensive emergency. And if the patient is presenting with confusion in USMLE with the raised hypertension, it is hypertensive encephalopathy until otherwise proved. Remember, in hypertensive encephalopathy, if the examiner wants to test you down, it would possibly be because of it would possibly indicate or be given in the question that there is raised blood pressure with the clinical features of headache, vomiting and altered mental status or confusion. Sometimes the examiner can also tell you that there can be weakness or there can be seizures or there can be coma as well. Please to remember that this patient has got blurring of vision indicates that the patient has got an end organ damage of retina, that is hypertensive retinopathy, that is usually seen. Whenever there is hypertensive retinopathy, what happens whenever there is hypertensive retinopathy? Hypertensive retinopathy can usually present with hypertensive exudates or the patient can present with the retinal hemorrhages. So what is the treatment for the patient who has got raised blood pressure and signs of end organ damage? It is usually the control of hypertension with antihypertensive medications. Now the examiner is interested which of the following is the most appropriate initial pharmacotherapy. It is the antihypertensive medication. So I will have to go search for antihypertensive medications in the option. Oral 81 milligrams of aspirin. I would not be giving aspirin if the patient has not got any stroke. Remember that. And this patient who is got a CT scan did not show any signs of acute ischemic stroke. So 81 milligrams of aspirin is not the answer. Even if the aspirin is the right option, the patient has not got the correct dose because 300 milligrams is the right answer. So I will not be selecting this option. Next we talk about another option where the examiner is talking about intravenous alteplase. Intravenous alteplase is usually done in infarct, embolus, but this is not the option here because the patient has got hypertensive encephalopathy. Intravenous dexamethasone is not a treatment option because intravenous dexamethasone is usually used in patients who has got edema because of the brain tumors. Next we talk about intravenous heparin, usually for a venous clot or patient who has got a embolic stroke. That is one thing that we have to use it. Next we talk about intravenous labetalol, which is the most important thing that we usually do. So intravenous labetalol is a drug of choice for hypertensive encephalopathy in these kind of patients. There can be another question such as if the intravenous labetalol is not available, what would you do? You can actually select another beta blocker such as esmolol, or you can select calcium channel blockers such as nicardipine, or you can select nitroprusside. All right, we'll see the next question. Very interesting questions in neurology. We've got plenty of options. We can do plenty of discussions with the options as well. I love these kind of questions. All right, he's talking about a 57-year-old man who is brought to the emergency department after he was found walking unsteady and speaking in a confused and incoherent manner. Remember, this patient is brought to the emergency department after he was found, but we do not know the time frame. Neurological examination shows bilateral abducens nerve palsy, coarse nystagmus in all directions and severe truncal ataxia. What is the most likely diagnosis is one thing the examiner is asking. Obviously, if the patient has got a sudden onset of symptoms, you'll have to think of a neurological emergency. There are very few neurological emergencies, usually hypertensive encephalopathy we just discussed, infarct, stroke, hemorrhages, and patient with the GBS or patient who has got some other metabolic abnormalities. But the examiner wants you to understand that this is a 57-year-old man who is brought to the emergency department after he was found walking unsteady and is not able to speak because he's confused and has got an incoherent speech. He's got bilateral abducens palsy, he's got nystagmus, and he's got truncal ataxia. What would be the first most important thing? It is Wernicke's encephalopathy I will have to think of, because patient who has got ataxia, patient who is confused, patient who is nystagmus and has got bilateral abducens palsy, my first most important thing is Wernicke's encephalopathy. However, we will also have to see other options as well, because I'm not sure what could be the right answer. We talk about diabetic polyneuropathy. Obviously, poorly controlled diabetes can affect the multiple nerves and can lead to diabetic polyneuropathy. Whenever there is diabetic polyneuropathy, it usually results in sensory motor findings. Sometimes there can be diabetic amyotrophy as well, where there can be pain. But diabetic polyneuropathy, that is very unlikely to produce multiple nerve palsies, and patient with the nystagmus and severe truncal ataxia would not be findings in diabetic polyneuropathy. However, there can be ataxia because of the involvement of the peripheral neuropathy, but presence of nystagmus and other multiple cranial nerve palsies are very rare. Next, we talk about Huntington's disease. I've done research in Huntington's disease, and I know that Huntington's disease usually do not present with bilateral nerve palsies. If it is a behavioral change, if it is involuntary movements, yes, I would love to choose Huntington's disease as one of the options, because we all know that it is because of the atrophy of the caudate nucleus, and this patient can present with behavioral change, and sometimes a patient can be followed with patient can present with psychiatric symptoms as well. But the most important thing you remember for USMLE is chorea and psychiatric movements. Next, we talk about lead encephalopathy. Whenever there is a lead encephalopathy, I would like to tell you that this can be associated with the cognitive impairment, and there can be problems with the lead neuropathy, that is peripheral neuropathy could be the most common thing. Obviously, whenever there is a lead encephalopathy, it is a type of element lesion. Whenever there is element lesion, it is usually presenting with hypotonia and hyporeflexia. The examiner could also be giving you clues to pick up lead encephalopathy, saying that the patient can present with constipation or abdominal pain, or sometimes that can be renal problems such as renal tubular dysfunction as well. Commonly, the examiner will tell you that the patient has got fatigue pointing out towards anemia, constipation, and abdominal pain as well. Next, we talk about multiple sclerosis. Multiple sclerosis is usually an autoimmune, and it is considered as a demyelinating disorder. But remember, to consider it as multiple sclerosis, you need to have multiple symptoms, or you need to have neurological symptoms separated in time, and you need to have the lesions separated in space. One most important thing that can be asked for USMLE is the patient can be given, or the examiner can give you that the patient has got central venous sign or central vein sign. That is a new finding, and that is a characteristic finding for multiple sclerosis. All right. Next, we talk about neuritic beriberi. Neuritic beriberi is nothing but, don't be amazed, neuritic beriberi is nothing but the patient who has got beriberi disease, that is dry beriberi is what he is talking about. All right, it is because of the B1 deficiency, thiamine deficiency as well. All right, it usually presents with peripheral neuropathy. Next, we talk about Parkinson's disease. Whenever there is Parkinson's disease usually presents as bradykinesia, rigidity, and tremors. Next, we talk about spinal cord glioma. Whenever there is spinal cord glioma, usually it is presenting as an upper motor neuron lesion. It is very unlikely to have bilateral abducens nerve palsies and nystagmus in a spinal cord glioma. Tabes dorsalis, again it is presenting with the loss of vibration and proprioception, not with the nerve palsies and nystagmus, please. There can be ataxia, but please to remember, nystagmus and nerve palsies are very rare in tabes dorsalis. Next, we talk about vitamin B12 deficiency. Whenever there is vitamin B12 deficiency, I would like to think that the patient has got loss of proprioception and vibration. It is not usual to be having bilateral abducens nerve palsies in patients who has got vitamin B12 deficiency. Wernicke's encephalopathy, it is usually the presenting symptom for nerve palsies, nystagmus and truncal ataxia in a patient who is brought to the emergency department and has got significant alcohol intake. That is one thing I will have to remember this. Sometimes the examiners would be very tricky and will be testing Wernicke's encephalopathy in some of the certain conditions. What could it be? There could be excess alcohol intake, patient with malnutrition, patient with starving, patient in ITU, patient critically ill, patient is on severe fasting and is started on some of the feed. That is one thing you will have to remember. Alright. So my answer here is Wernicke's encephalopathy. The examiners can be asking you, why does patients with thiamine deficiency develop Wernicke's encephalopathy? This could obviously be a part 1 question because thiamine plays an important role in maintaining the axon conduction or nerve conduction. And thiamine also plays an important role in neurotransmitter synthesis. Thiamine deficiency, whenever it is present, it is usually because of the oxidative mechanisms that are being aggravated, and the oxidative mechanisms, when they are aggravated, leads to toxicity and that causes vitamin B1 deficiency or thiamine deficiency. Sometimes there is another severe disease called as Korsakoff syndrome, where the patient presents with confabulation. This is one thing you will have to remember, please. Alright. Remember, whenever you are treating thiamine deficiency, please do replace thiamine with glucose. This is one thing you'll have to remember, please. Alright. We'll see the next question. The examiner wants to talk about which of the following is the most likely location of the abnormality. He's talking about a 24-year-old man who is coming to the physician one day after he had generalized tonic-clonic seizure at work. His symptoms began with a rising sensation in the upper middle abdomen. His co-workers told him that he started to stare, licked his lips and then fell onto the floor. He had generalized shaking of his arms and legs. After he awakened, he was confused for several minutes and smelled an odor of burnt rubber that his co-workers did not notice. He has noticed a similar odor 3 times in the past 2 months. He was hit by a baseball bat and at the age of 12 years, he had a brief loss of consciousness. He has been otherwise healthy. Physical and neurological examination shows no abnormalities. Which of the following is the most likely location of the abnormality? Obviously, I could understand that this patient has got a generalized tonic-clonic seizure where this patient has got a sensation where this patient is rising. The abdominal sensation is rising or the rising sensation that has been began. Obviously, we understood that this patient could be having a focal seizure. And this patient who's got a focal seizure now presenting with generalized tonic-clonic seizure along with the patient who has got symptoms that such as started to stare, licked his lips and then fell on the floor. This is one thing you'll have to remember. This patient has got signs of automatism. He had generalized shaking of his arms and legs. After awakened, he was confused for several minutes. Now that I could understand, this patient has got obviously a confirmed seizure. And now he also mentions that there is a generalized burnt rubber. It is nothing but olfactory thing. It indicates that the patient has got a temporal lobe. Obviously, we will also see how other options are not wrong, not right. Brainstem, whenever there is brainstem involvement, it is usually presenting with the generalized tonic-clonic seizures because there will be reticular activating system as well. I would like to tell you that. Next, we talk about cerebellum. Whenever there is cerebellum involvement, it is usually characterized by movements. But cerebellum involvement in epilepsy is very rare, and cerebellar involvement, whenever it is present, the patient usually presents with shaking of the legs. Frontal lobe, whenever there is frontal lobe, usually patient will be having focal seizures with impaired awareness. And frontal frontal lobe seizures usually can lead to speech disturbances and complex automatism, but obviously we know that the frontal lobe is most important for social situations, emotional control. So all this will be lost if there is a frontal lobe seizure. Occipital lobe, if you want an occipital lobe seizure, the patient will tell you that the patient has got colored lights, patient has got visual symptoms, but please do remember, for USMLE, for you to call it an occipital lobe, you will need to differentiate it from migraine, and patients needs to have more than 5 minutes of flashing of lights in order to consider occipital lobe. Next, we talk about parietal lobe. Whenever there is parietal lobe, please do remember that the parietal lobe can also cause focal seizures, but there can be tingling, numbness, or there can be involvement of the language or comprehension or speech abnormalities if the parietal lobe is involved. Temporal lobe, when it is involved, it is basically because of the auditory hallucinations that we will be thinking of. All right, automatisms as well. We'll see the next question. The examiner wants you to talk about which of the following is the most appropriate therapy to decrease the patient's risk for a stroke. Very common question, usually asked, please. 67-year-old man who has 4 acute episodes of aphasia over the past year. His temperature is 37, pulse is 84, respirations are 12, blood pressure is 142, serum study shows a glucose concentration of 150, total cholesterol of 296, HDL cholesterol of 28, and carotid ultrasonography shows 90% stenosis of the internal carotid artery on the left side. And he had 4 episodes of aphasia. Whenever the patient mentions, the examiner mentions that the patient has got 4 episodes of aphasia, I will have to remember that this patient have got multiple transient ischemic attacks. All right, and he did not give me the duration of the episodes, but I might have to consider that this patient might be improved, or he did not give me the examination findings, so I cannot consider if this patient has got a stroke or not. Given that this patient has got 4 episodes of similar problem, I am thinking that this patient might be developing a transient ischemic attack, and this transient ischemic attack is usually caused by hypertension, smoking, diabetes, hyperlipidemia, and hypercoagulable states as well. In this patient, everything is present, but the most important thing is an ultrasound with 90% stenosis of the left internal carotid artery. That is what I can remember. So I would have to make sure that I need to correct the carotid artery first. So carotid endarterectomy is the most appropriate therapy to decrease the patient's risk for a stroke. We will also see why other options are wrong. Control of blood pressure with the diet and medications. Yes, you can do that, but the problem here is the left internal carotid artery has got a 90% stenosis, which does not improve or which does not decrease the patient's risk for a stroke, given that this patient has got 90% stenosis. Control of LDL concentration with the diet and medications. Control of LDL would be very difficult again, so it would not be an option again here. Alright, all these are the secondary methods of prevention. Control of ventricular rate with the digoxin. I'm not worried about the rate with the digoxin here because he did not give me the ECG findings. So I'm not worried about this one. Alright, control of serum glucose with diet. Again, it is a secondary prevention. Aspirin therapy is a primary prevention, but the problem here is 90% of the internal carotid stenosis. That is one thing I will have to remember. Alright. Next is warfarin therapy. Warfarin therapy is not at all used for the stroke. Please do remember that. Alright. However, if the patient has got atrial fibrillation, you'll need to calculate Chad's VASC score, and then you will have to think of other prevention such as aspirin or warfarin. But this is not valid in this question because he's already got 4 episodes of aphasia. He's got multiple TIAs with the 90% stenosis. That is why I would like to go ahead with carotid endarterectomy. But the most important thing you will have to remember is patient who has got 70% to 99% of stenosis, they must undergo carotid endarterectomy, or sometimes the examiner can give you the option of carotid stenting as well. Please do remember that this is one of the most important thing you will have to remember. All right. Thank you very much. I'll see you in the next session. All the best. Thank you.